right, well, I would love to welcome Dr. Marie Morse. She is a board-certified adult neurologist with special qualifications in child neurology and board-certified fellowship trained in sleep medicine specialist. She is the director of child neurology and pediatric sleep medicine at Janice Weiss Children's Hospital, Geisinger Health Systems. Dr. Morse is internationally recognized as a key opinion leader in sleep medicine, especially with regards to central disorders of hypersomnolence, such as narcolepsy and idiopathic hypersomnia. She has proudly embraced her reputation as a healthcare disruptor, challenging the current delivery of care, embracing digital transformation, and advocating for new treatments and delivery of care that is through partnership with the patient and community, personalizing their wellness journey to their individual needs. And as a result, Dr. Morse is highly regarded advisor for multiple advocacy organizations, biomedical companies, and well-established industry partners. Her commitment to effective change, as well as engaging and activating individuals in their own care journey, is illustrated by the success seen in her programmatic development of novel, asynchronous, integrated, personalized sleep health programs. Sleep to Be Well and Wake Up and Learn represent first ever novel sleep command centers that provide virtually delivered sleep education, screening, and intervention that reaches individuals across the clinical setting and within the community. And it would be amiss not to comment on her commitment as a scientific advisory board member and champion for Sleep Consortium, endorsing the bold innovative approach to putting patients as the drivers to innovation and discovery. She's also been regularly involved with the Hypersomnia Foundation and deeply committed to our mission and our community. Welcome, Samuel and Hayley. I'm going to ask you both to do a quick intro of yourselves, who you are, where you are, and anything you want to say that's relevant to this panel. So Hayley, perhaps you can start.
Sure. Hello, my name is Hayley Wall. I have IH. I've been diagnosed for a little over 7 years now. I am an advocate, patient advocate, but I'm also an occupational therapist. So I, use a lot of my knowledge to help me get through my day with brain fog and IH symptoms in general. I'm tuning in from Texas, and I'm really happy to be here.
Thank you, Hayley. It's lovely to see you. Samuel, where are you?
Hello, can you hear me okay?
Yes, perfect.
I'm Sam. I've been diagnosed for 3 years. I live in Chicago. I'm pretty familiar with the struggles of IH and am happy to share my experiences and
Thank
put
you.
in a word or two.
Yeah, I'm going to definitely tap you both for some of your experiences around brain fog. All right. So first to you, Dr. Morse. Amber asks, can you be diagnosed with idiopathic hypersomnia and narcolepsy type 1?
Okay, so I'm going to say something very, very controversial. And that is that if I were to look at, so if you were to speak to me maybe 5 to 10 years ago, I would adamantly say absolutely not. And the reason why I would say absolutely not is because if you were to look at the international classification of sleep disorders, edition 3 or edition 2 or edition 3 text revision, they all are going to give you the same description that narcolepsy type 1, yes, you can diagnose it with CSF testing. However, it would be with a polysomnography, an overnight test with a following day MSLT. An MSLT that must show that there is an average sleep latency of less than 8 minutes and 2 or more sleep onset REM periods, either one on the polysomnography and one on the MSLT. Where if you look at IH, the diagnosis is the difference of 1 SO REM, which is I have an average sleep latency of 8 minutes and that I have less than 2 sleep onset REM periods. So based on those diagnostic criteria, it would be impossible to have both because of the fact that they are negating one another. What I'm going to say that's controversial is that I do believe that individuals can have both of these disorders. And so the reason I state this, and again, please don't take this as gospel proof or a gospel truth and go to your doctor and tell you that Dr. Morse diagnosed you with both. But the reason I state this is because at this point, the etiology that we know of one form of narcolepsy type 1 is that there are individuals who can have CSF deficiency of orexin, and that can produce the symptoms of narcolepsy type 1. With narcolepsy type 2 and IH, we do not have a full understanding of the pathophysiology. And so, as I had mentioned to you, I love the statement by Carl Sagan, the absence of evidence is not the evidence of absence, which is if I do not know the physiology or the pathophysiology that causes narcolepsy type 2 and IH, how can I possibly tell you that you can't have both? And there are plenty of people who walk around who do have symptomatology that is suggestive of a correspondence to what looks like IH and a correspondence that looks like narcolepsy type 1. And so, could there be physiology that they have uniquely that is dysfunctional and representative of both? And I truly do believe that that is a possibility that can occur.
Okay, Shell's asking about brain fog. So perhaps Haley or Sam, you can think about this as a relatable situation. She says, is brain fog the reason why it's so difficult to get the emotional energy to exercise? With comorbid conditions and long-term need for PT, I'm needed to do exercise at home, but I just don't have the emotional energy to even do daily stretches. Haley or Sam, do you want to take that?
Do you mind if I grab this one?
Of course.
Okay.
Please do.
So I struggle with that personally because you need to exercise to sleep well, but some days it's so difficult to get the energy to exercise, which affects the whole the whole thing, and then it makes the next day more difficult. So I would say yes, but depending on the day, sometimes it is good to just try and push through, but some days you just can't. It's brain fog is foggy. It can just make the whole experience much more difficult. You know what you need to do, but you just can't. So be nice to yourself.
Yeah. Haley, can you relate to that?
I definitely can. I think it plays into the cognitive aspects of, the executive functioning, the planning, initiation. During brain fog times that are more severe, I definitely find it a lot harder to plan where I'm going to insert that in my day, especially when I have necessity type obligations, in addition to also wanting to, engage in my wants, my hobbies, my interests. So I think that brain fog plays into it where, okay, when does necessity obligation stop? And then, the self-care, taking care of physical health start. That's where I can see it playing a more of a role in my life.
Yeah, that's a good answer. Helpful, thank you. Nanette says there's probably a question for Dr. Morse. Do you think there'll ever be a brain fog questionnaire for doctors to give to patients? For years, I complained to the doctors about my ADHD meds. They still did not help me to think clearly enough, and I was unaware all these years it was brain fog that I was experiencing. Will there be a questionnaire for patients?
So I think that there are many different fields who are going towards creating brain fog questionnaires. One of the things that I always say, this is my perspective on, I love biomarkers, I love validated surveys for research. The biggest thing that when we are using them in a clinical setting is we run the risk of invalidating what people are experiencing because the words we're using on a survey aren't matching the lived experience that someone is having. Now, with that stated, similar to what you have experienced is the opposite of that. What you were saying and describing was being captured as this is ADHD. And there probably was components of what you were experiencing that had ADHD features. But really, the call to action that needs to occur is when an individual is describing to you symptoms that are persistent and not getting better. In medical school, we're taught reevaluate the diagnosis that you made. You're missing something. And so this is where I go back to leaning into, please be empowered by knowing where you're coming from and what you're experiencing. Because if what the information you're getting back from a clinician is telling you words that don't fit what you're living, that is better than any questionnaire that will ever be developed.
Very good. Thank you. Okay, Daniela asks, I understand that Xywav creates a deeper REM. If my daughter is on an SSI medication and SSRIs are known to affect the suppression of a number of REM episodes, can the SSRI, in this case Prozac, be contributing to hyperemia issues? That's definitely a Dr. Morse question, I would say.
Sure. So when looking at oxybates as a class, the physiologic impact it has on what we call the ultradian cycling, so this is how we cycle through sleep, is that with the acute, when you first start, there sometimes can be a REM exaggeration, but it actually is a REM suppressant. What we see is an exaggeration of actually slow wave sleep, which is a restorative stage of sleep. And is one where I do think oxybates have a unique benefit in IH, because my theory, and again, this is not gospel truth, this is my theory, is that there is a disconnection between how our homeostatic sleep drive, where slow wave sleep is relevant, and how our circadian rhythm, which is how we cycle through the day, are disconnected, and that we may have a greater degree of slow wave sleep. Or desire for slow wave sleep. And so I do, I would say to you that the two should not have an interaction between an SSRI and any of the oxybates. In fact, it is very, very common that we're using these medications in combination because these medications are very commonly being used for a variety of reasons in both narcolepsy and IH.
Thank you. I'm going to jump around a little bit here because there's a specific OT question. So perhaps Hayley would share would like some ideas of what an occupational therapist could actually do to assist someone with IH and their symptoms. I've seen them before and they don't seem to know anything. As an OT and a person with IH and someone who's combining those interests, what would your answer be, Hayley?
So my answer is you're not wrong. Sleep disorders in general, I think, aren't talked about nearly enough in my profession. So I've kind of made it my goal, and I'm working to, try to expand that conversation. But my views would be working toward, some of those cognition pieces for executive functioning, because that's where, in my personal experience, I see a lot of that brain fog and IH symptoms really impacting working memory, all those types of things. So for when I was in college, I had different accommodations that supported me through, OT school. One being a recording pen that my university provided to me. So if I was experiencing, really brain fog type moments in my classes or longer lectures, I could then go back to them and re-listen to them on my own time to help, supplement those areas in my life where, sitting for longer periods of time, it just does not do well for me. So, working on those aspects. Some things I've used in my own life, there's not research. So again, this is just my own personal experience, is using a lot of sensory strategies to help alert my system, being, crunchy foods or sour, the temperature in the air, movement in general. Those types of strategies have really helped me. So I've shared a lot of that on some of my social media, and other people have responded that, they gave it a try and that helped too. So I could see, potentially areas in the sensory systems targeting the nervous system, and then just supports to help, plan throughout the day, priorities, and really making sure that you're not only engaging in the obligations, but your wants and desires. You're living a full, meaningful life that feels good. That's kind of where I see it. Still a work in progress, and I'm hopeful for a better integration in the future.
Yeah, it is a really interesting undiscovered field, perhaps, in relation to sort of helping people with sleep disorders. And for those of you listening, you can actually find Hayley on social media, and some of her TikTok videos actually, where she's actually showing how sensory food can help with alertness, for example, have been extremely gained a lot of traction. So you can, in fact, welcome our panelists here to put their social media handles in the chat. Staying on that theme with Reddit, there's a question here. Perhaps Sam, you could speak to this. The Reddit threads have provided good material for research. Are there any specific Reddit groups or any of you that would recommend being more useful than others for sharing information such as experiences with doctors and medications for IH? I'm not on Reddit, so I can't help with this one. Any comments about Reddit?
There is a idiopathic hypersomnia Reddit group. I think that might just be what it's called, is idiopathic hypersomnia support. But I actually have gotten a lot of help from there, just asking other people's advice about like recently I was trying Xywave, and for some of my acquaintances, it's been a total game changer and it worked really well. And I was really excited for that to work well for me, but everybody's body's different. So I was like, hey, has anybody else experienced anxiety while they're on Xywave? And there was a couple people that were like, oh yeah, I call it the doomies. And I started calling it that too. But it is nice. I've also gotten a lot of like exercise advice from that same group. And I think that's how I met up with you guys at some point a couple of years ago.
Yeah. Dr. Morse, do you want to say anything about social media while we're on the topic?
Yeah, I would say that for me, social media, I went to social media because I run a division of child neurology and pediatric sleep medicine. And although I see patients who have hypersomnolence, adult and peds, my pediatric patients are definitely social media users. And so either them or their parents would come in. Parents came in with Facebook, the kiddos came in with their TikToks and their Instagrams. And it was a mixture of who would tell me about Reddit. But they would tell me things that either I did not know and was medically accurate, or they would tell me things that I'm going, no, 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 no. That's a partial truth, or that's inaccurate, or that's risky. And so it really drew me to social media, to be able to be a part of it, right? Most physicians are going to tell you, don't believe what you see on the internet. Don't believe in those groups. So I smack the hands of my residents who do those types of things, because that disempowers the person who is living their life. How dare you, as a clinician, tell a person that you're the only source of information that's reliable, because that's wrong every single time. But it also deprives individuals of community, right? The people who are on this today, they're a part of a community. They're a part of the Hypersomnia Foundation community. You are amongst friends, and sometimes this even feels like family for many people, because they don't have their own family who understand and support them. But I do believe that social media has been a place of a brilliant discovery. I have been very, very fortunate to not only be a part of social media and be someone that gets tagged a lot in Reddit, or responded a lot in TikTok or Instagram or otherwise, but also have been able to do tremendous work with companies like Trend Community, where they utilize machine learning that's way smarter than I can be. I was learning from being an N of one and having individual conversations. Being able to elevate a community's voice by understanding the themes, understanding the struggles, has led to the ability to understand where we are not treating patients right, where there are struggles that they're embarrassed to share with us, or scared to share because it's a controlled substance or whatever it might be. And so it really has changed my clinical practice to be able to have a much more transparent conversation. It also has changed clearly my medical education on how I teach my future clinicians on, this is the way you partner with patients, not parent them.
And you can follow Dr. Morse at Damn Good Sleep on social media. That's DAMM, Good Sleep. Okay, another question for you, Anne-Marie. Oh wait, hang on. Do people who experience brain fog have a higher risk of experiencing a stroke and developing frontal lobe dementia?
Yeah, so that I would say that that would be a very difficult question to say yes or no to, and I don't want to inappropriately say no. And the reason why I say that is not that I have empiric evidence to say that yes, someone may be potentially at risk, but there can be disease states that are dementing disease states that can manifest as brain fog in early stages, and therefore you could see a consequence. I would say in the kind of all comers who have the features of brain fog, we do not have evidence to say that they would be higher likelihood of experiencing those things.
And a question to the panel. Can either of the patients on the panel speak to using Xywave? I'm curious if it might help me. And I don't know anyone who's ever taken it. Haley, Sam, you're muted.
I do not currently take and have not ever taken Xywave, so I cannot give much on that.
Okay. Sam?
I took Xywave. It's been really good for some people. You really have to listen to your doctor and make a good plan. It's really important to titrate properly, which is I don't hopefully I'm pronouncing that properly, but you really have to stick to a certain schedule and build up to a specific dose. It's not a medicine to take lightly, but it has been positive for a lot of people in the community. So I would talk to your doctor, and fingers crossed, that would be nice.
Claire, if I can just, I know that I'm not a patient taking it.
Oh,
However, I would say that I am a clinician who prescribes all oxybates. I also was a part of, again, I always like to make sure I'm doing full disclosure. I also was a part of the clinical trial. And if you look at the publications, I'm one of the authors or primary authors on most of those publications. Now, with that stated, what you're going to hear me say is not going to be just an advocacy for Xywave. What I'm going to say is that we are in a position right now where Xywave is the only FDA approved oxybate for idiopathic hypersomnia. However, you have 3 oxybates that are currently available, and that is your twice nightly sodium oxybate, twice nightly mixed salts oxybate, and your once nightly sodium oxybate, Xyrem, Xywave, Lumryz. With that stated, all 3 have different pharmacokinetic profiles, meaning that when you take them, your body will experience them differently. And so in the case of someone like Sam, where he's describing that he didn't have the most optimal experience, there's a lot of things that I would potentially want to understand about that, because there are different strategies. Like sometimes people do experience mood changes and I need to add temporarily an SSRI for them to be able to tolerate it better. Sometimes I need to move it back for a little bit and allow them to be at a dosing. I tend to start every patient who has idiopathic hypersomnia, whether it's Xyrem or Xywave, once nightly, and titrate them up unless they show me that they're going to wake up 2.5 to 4 hours later, rather than forcing them to arbitrarily wake up 2.5 to 4 hours later. You can get up to 6 grams. And then with that stated, you can always consider, are there other opportunities to improve it? But the reason I want to make this particular call out is because the data that we have from the Xywave studies are substantial and they're very impactful. Yves Dauvier in France had done a randomized controlled trial with Xyrem and demonstrated similarly very robust, substantial data. And although we don't have data from Lumryz, I would have a very, very strong suspicion that we would experience that there would also be a tremendous benefit. So the reason I want to make this statement is because we know in narcolepsy, where these are 3 drugs that are available, they're still gravely underutilized and underoffered. For individuals who have idiopathic hypersomnia, where you're limited in what you're able to get, the oxybate family of medications may be ones where if you are not doing optimally on one, that you can consider different strategies with others.
Yeah, thank you for that clarification. I think we're almost at time. Perhaps there's one last question. You may have touched on it actually, Dr. Morse. What medications, just tying off with the brain fog piece, what medications, if any, have been successful to treat brain fog in other conditions that might give hope to people with sleep disorders?
Yeah, so what's very interesting when looking at other conditions, there's a question of what is contributing. And so sometimes when looking at other conditions like celiac disease or multiple sclerosis or otherwise, what first tends to be most beneficial is better control of that primary disease. So if it's an inflammatory condition, making sure you're getting better inflammatory control. There have been some studies that have looked at a variety of different stimulants and alerting agents, and you see mixed responses. And the reason that I think you're seeing mixed responses is also what has been the characterization in those other conditions of, is there a comorbid sleep-wake disorder present? And are you treating sleepiness or are you treating brain fog?
Thank you. That's a great way to close. We're at time. It's been an incredibly stimulating morning. I do want to extend my thanks on behalf of the Hypersomnia Foundation to our amazing speakers and our panelists, and to all of you for joining us today.